Assalamu alaikum wa rahmatullah. First of all, I would like to thank my dear professors and the organizing committee for giving me the chance to participate in NephroAlex scientific program. My talk today will be about sodium abnormalities. Sodium is the most abundant extracellular cation. It is one of the most effective osmoles in the serum, and it plays a pivotal role in fluids and the electrolyte balance, as it accounts for half of the osmolarity of the extracellular fluid. And thus, changes in serum sodium can lead to changes in the extracellular fluid tonicity. We will start by hyponatremia. Hyponatremia is defined as serum sodium level below 135 millimole per liter. As regards the epidemiology, it is the most common electrolyte disorders faced practically in clinical practice. It affects about 15 to 30% of hospitalized patients and 7% of ambulatory patients. It can cause 1 million hospitalizations per year, and it has high incidence in common comorbid conditions like cirrhosis, congestive heart failure, and also has high incidence in geriatric population. Hyponatremia is important clinically because it can lead to substantial morbidity and mortality. Also, hyponatremia per se is an independent risk factor for mortality in the setting of MI, cirrhosis, and in chronic kidney disease. Also, over rapid correction of chronic hyponatremia can lead to osmotic demyelination syndrome, leading to severe neurological deficits and sometimes death. Hyponatremia can be classified according to the sodium level into mild, moderate, and profound, with profound hyponatremia meaning sodium level less than 125 millimole per liter. It can be also classified according to the presence or absence of symptoms into asymptomatic or mild or severe, with severe hyponatremia presenting with seizures and coma. It can be classified according to the duration into acute and chronic hyponatremia, where acute hyponatremia has duration less than 48 hours and the chronic hyponatremia has duration more than 48 hours. And here an important point is that the severity of the neurological symptoms doesn't correlate with the absolute figure of sodium level. However, it correlates well with the rate and the degree of drop in serum sodium, where a gradual drop in serum sodium, even to very low levels, if it occurs over a period of days or weeks, because of neuronal adaptation, it can be asymptomatic due to loss of intracellular organic osmolytes from the brain cells to the extracellular fluid. Also, the presence of underlying neurological disease or metabolic abnormality like hypoxia, hypercapnia, or acidosis, all of them can affect the severity of the neurological manifestations. Why neurological manifestations occur in hyponatremia? Because hyponatremia leads to hypoosmolarity of the extracellular fluid. So this causes shift of fluid from the extracellular compartment to the intracellular compartment, and this inside the brain cell can lead to brain edema, compromising cerebral blood flow, leading to hypoxic brain damage, and if the condition is severe and left untreated, herniation into the foramen magnum can occur. Regarding approach to hyponatremia, it requires a systemic and sequential approach. The first step is thorough history taking to confirm history of losses, whether from the GIT or losses from the kidney, history of drug intake like diuretics, antipsychotics, antiepileptics, or antidepressants, which can cause SIADA syndrome, and also careful examination to estimate the volume status of the patient. The second step, which is the most important step, is to confirm the presence of true hyponatremia by a calculation of serum osmolality, to confirm the presence of true hypotonic hyponatremia, which is important clinically because it carries the risk of brain edema. So it is important to rule out hypertonic hyponatremia as in cases of presence of osmotically active substance in the serum, like in cases of hyperglycemia, or pseudo-hyponatremia, which leads to laboratory artifact in estimation of sodium, as in cases of paraproteinemia and hyperlipidemia. The third step in the approach is to estimate the urine osmolality, urine sodium, and volume status of the patient, and the fourth step is laboratory test to address the underlying cause of hyponatremia. This is the equation used to estimate the serum osmolality. It is 2 multiplied by sodium plus blood urea nitrogen over 2.8 to confirm the results, to convert the results to millimole per liter, and glucose over 18 also to convert it into millimole per liter. This is the diagnostic algorithm obtained from the European guidelines for the management of hyponatremia. The first step is to confirm the presence of hypotonic hyponatremia, and then we will see if the patient is presenting with severe symptoms. Then we will give hypertonic saline, as we will see in details in the treatment section. If there is no symptoms, then we will start a cause-specific approach. We will estimate the urine osmolality before performing urine sodium. The guidelines give priority for urine osmolality. If the urine osmolality is low, this is in favor of primary polydipsia or low solute intake or beer potamania. If the urine sodium is high, we will estimate urine sodium concentration. If the urine sodium concentration is low, this patient may have a volume depletion due to non-renal losses, as from the GIT or third space loss, or maybe the patient is overloaded also, like in cases of heart failure, liver cirrhosis, or nephrotic syndrome. As in this situation, the effective circulating volume is low, and this causes upregulation of the RAS system, leading to retention of sodium. So urine sodium doesn't differentiate between hypovolemia and hypervolemia in this context. That's why there is priority for urine osmolality before urine sodium. If the urine sodium is high, this patient may be taking diuretics or have kidney disease. If no, we will start to estimate the volume status of the patient. If the volume status looks normal, eovolemic hyponatremia, this is in favor of SIADA or central adrenal insufficiency or hypothyroidism. If the extracellular fluid seems to be contracted and the patient seems hypovolemic, this may be primary adrenal insufficiency due to depletional sodium, or renal salt wasting, or cerebral salt wasting, or sometimes severe vomiting due to obligatory loss of bicarbonate and sodium in urine. Regarding the treatment, when considering the treatment of patients with hyponatremia, certain issues must be addressed, like the risk of osmotic demyelination, appropriate rate of correction to minimize this risk, and management of patients in whom over rapid correction has occurred. We have European guidelines for the management of hyponatremia, and factors to guide treatment include the patient volume status, the duration and magnitude of hyponatremia, and the degree and severity of clinical symptoms. The guidelines divide the treatment into whether it is symptomatic or asymptomatic. Symptomatic hyponatremia, whether acute or chronic, if the patient is presenting with serious symptoms, we will give bolus hypertonic saline over 20 minutes to be repeated 2 to 3 times as needed, with the target increase of 5 millimole per liter. If moderate symptoms, it is sufficient to give single bolus hypertonic saline. If symptoms improved, we will stop hypertonic saline and continue infusion of normal saline until a cause-specific treatment is available, with target sodium level 130 millimole per liter and limits not exceeding 10 millimole per liter in the first 24 hours and 8 millimole per liter per day thereafter. In case of no improvement of symptoms after this 5 millimole per liter increase in sodium concentration in the first hour, we will continue hypertonic saline, aiming for an additional 1 millimole per liter per hour increase in sodium, and stop whenever symptoms improved or limits exceeded. Equations to guide treatment if infusion is used needs to estimate the total body water, knowing that the total body water is 0.6 in males and 0.6 in females less than 65 years of age, and 0.5 in males and 0.45 in females more than 65 years of age. Also, we have a Drog-Medius equation which estimates the change in serum sodium per liter of infusate used to correct hyponatremia, knowing that each liter of normal saline contains 154 milliequivalent sodium, and each liter of hypertonic saline contains 513 milliequivalent sodium. In case of asymptomatic hyponatremia, if it is acute, we can initiate a cause-specific treatment unless there is severe drop of about 10 millimole per liter. We can give single bolus hypertonic saline. In case of asymptomatic hyponatremia and it is chronic, we will estimate the volume status. If it is SIADA, meaning that the patient is having eovolemic hyponatremia, the first line treatment, of course, is fluid restriction to decrease total body water. The second line is to increase free water excretion via the use of loop diuretics and oral sodium chloride tablets, or the use of urea to enhance osmotic diuresis, knowing that the taste of urea is very bitter, but now there is a formulation with a better taste that can be used. The guideline recommended against the use of the methylocycline to induce nephrogenic diabetes insipidus, as there are reports of hypersensitivity reaction and interstitial nephritis, and also it recommended against vaptens in profound hyponatremia due to the concern of rapid correction with the risk of osmotic demyelination, and also because the hepatotoxicity of vaptens, and also systematic reviews addressing the prognosis of patients with chronic hyponatremia maintained on vaptens versus placebo didn't yield significant results as regard good prognosis in patients taking vaptens. If the patient is having hypovolemic hyponatremia, we will give normal saline, and if the patient is having hypervolemic hyponatremia, we will give fluid restriction and diuretics, and also it recommended against vaptens. We will move the vaptens for the sake of time. What about osmotic demyelination? Osmotic demyelination syndrome. There are risk factors for osmotic demyelination, which are patients having low plasma osmolality from the start due to very low serum sodium level, concurrent hypokalemia, alcoholism, malnutrition, or advanced liver diseases. It occurs if chronic hyponatremia is corrected too rapidly, and characteristically the patient presents with a stereotypical biphasic pattern. Initially, there is improvement of the symptoms of hyponatremia, followed by progressive neurological deficit 1 to several days later. The most frequently affected area in the brain is the bones, so the patient presents with the lock-in syndrome, having bulbar manifestations and quadriplegia, and responding only with vertical eye movement due to sparing of the oculomotor nerve in the midbrain. The term central pontine myelinosis used in the past is now considered misnomer, as it has been discovered that the syndrome can affect other areas in the CNS as well, not only the bones. If there is excessive correction of chronic hyponatremia, if the starting sodium level is low, we will withhold the ongoing treatment and consider further relowering of serum sodium by giving infusion of electrolyte-free water at a rate of 10 ml per kg, and sometimes we can give desmopressin analog 2 microgram to be given every 8 hours. The second topic is hybernatremia. Hybernatremia is defined as sodium level more than 155 milli equivalent per liter. As regard the epidemiology, from about 8,000 patients in 12 French ICUs in 2018, it was found that 11.1% developed mild hybernatremia and 4.2% developed moderate to severe hybernatremia 24 hours or more after ICU admission. Risk factors for hybernatremia included advanced age, mental or physical impairment, making lack of access to water, uncontrolled diabetes, diuretics, polyuria disorder, or residency in nursing home and hospitalization. It carries a mortality rate of about 30 to 48%, especially if serum sodium exceeds 150 millimole per liter. And also in a Turkish study, independent risk factors associated with mortality from hybernatremia were found to be concomitant low systolic blood pressure, low pH, very high sodium level, increased plasma osmolality, concurrent pneumonia, dehydration, or mean sodium reduction rate of 0.134 millimole per liter per hour or less. Hybernatremia can be caused by loss of water or gain in sodium in excess of water, and thus the patient can be divided into hypervolemic, normovolemic, and hypovolemic hybernatremia. Again, the manifestations are mainly neurological due to cellular dehydration affecting the brain cells. But also we can find signs of volume depletion like orthostatic hypotension, tachycardia, oliguria, and dry skin and mucous membrane. In cases of hypovolemic hybernatremia, here there is loss of water in excess of salt. It can be divided into renal water loss, and here the urine osmolality will be relatively low and urine sodium is high, as in cases of intrinsic renal disease or buluric phase of ATN or use of diuretics. In cases of non-renal water loss, it is favored by relatively high urine osmolality and low urine sodium, as in cases of gastrointestinal and cutaneous losses. Cases of normovolemic hypernatremia, here the normal response of the kidney is to increase the urine osmolality above 800 milliosmol per kilogram water. So it is divided into renal and non-renal causes. In non-renal causes, here the kidney responds well by increasing urinary osmolality, as in cases of isolated hypodipsia, meaning lesion affecting the thirst center in the hypothalamus, or increased insensible losses. In case of renal water loss, here we mean diabetes insipidus, whether central, nephrogenic, or gestational, and here the urine osmolality is usually low, less than 300 milliosmol per kg. In cases of hypervolemic hypernatremia, this is usually iatrogenic due to administration of sodium-containing fluids like bicarbonate, hypertonic saline, or sodium chloride tablets, or hypertonic alimentation solution used in intensive care units, or less commonly mineralocorticoid excess like Cushing syndrome, hyperaldosteronism, and congenital adrenal hyperplasia. As regards the algorithm, the cause of hypernatremia is usually evident from the history and the physical examination, and is typically water loss or restricted access to water in elderly, comatose, or intubated patients. If you cannot reach the diagnosis or the cause of hypernatremia from history and examination, we will perform investigations, and we can consider trial of vasopressin if diabetes insipidus is suspected, or measuring aldosterone or cortisol level. As regards the recommendation of treatment, if it is acute, the maximum correction rate should not exceed 12 milliequivalent per liter per day, and if it is chronic, the maximum correction rate should not exceed 8 to 10 milliequivalent per day. And if the patient is presenting with hypovolemic hypernatremia, the priority is to volume resuscitate the patient with isotonic saline prior to free water administration, as hypovolemia is much life-threatening than hyperosmolarity. The same equations used in the management of hyponatremia also apply in the estimation of the correction rate in cases of hypernatremia. And this is example of the common types of fluids used in correction of hypernatremia, like glucose, half normal saline, ring lactate, and normal saline. Once hypernatremia is corrected, then we will start to treat the underlying cause. For example, correction of hypokalemia and hypercalcemia in cases of nephrogenic diabetes insipidus, vasopressin analog, whether orally or nasally, in cases of central diabetes insipidus, and in hypervolemic hypernatremia, we can give diuretics, and sometimes dialysis may be considered. Thank you.